We have the last speaker now, Dr. Anand Bhosle. I request him to come up, please.
Good afternoon, everybody. I'll be presenting a case on anterior segment reconstruction with artificial iris and a toric scleral fixated lens in a case of traumatic globe rupture repair. I don't have any financial disclosures pertaining to this case. The challenges in the recovery of globe rupture repair are aphakia, astigmatism secondary to the scarring of the cornea and the sclera, aniridia, and secondary choroidal sequelae like retinal membrane formation and incarceration of the retinal tissue. So we had a 69-year-old gentleman who had a history of fall. He gave a history of previous cataract surgery. Apart from that, there was no other positive contributing history. Here we can see a globe rupture with a squashed globe. And on doing a thorough peritomy, we could see that there is a scleral tear at the limbus or maybe within 1 millimeter, and patient had aphakia. As we all would do, we did a standard repair with 70 Vicryl. AC was well formed, and here we can see a well formed AC, and the case was closed. At 3 months follow-up, the patient had aniridia, aphakia, and on OCT he had a retinal membrane. So the challenges we were facing here was high astigmatism, 4.5 diopter cylinder, but for surviving his BCVA was 612 parts. Patient was very keen on visual rehabilitation. So he had no iris and aphakia with high cylinder, so what could be done? So we decided to do biometry, which showed 20 diopter of IOL with almost 5 diopter of cylinder at 57 axis. We sent the patient's pictures comparing the better eye, which was the right eye, to the company, and they created an artificial iris for us. These markings are at 57 degrees where the desired toric scleral fixated lens is to be placed, and incisions and sclerotomies were done at 1.5 and 3 millimeters. After doing these sclerotomies at 1.5 millimeters, vitrectomy was performed and epiretinal membrane was peeled off from the macula so that the distortion is taken care of. We aim to fit the lens at 57 degrees. This lens was used with a CV8 Gore-Tex suture with a 70 size, and Gore-Tex is passed through the eyelets of the holes at the optic haptic junction, and these are exteriorized. After exteriorization, we make sure that there is no entangling of the sutures, and this lens is folded with a hold and fold forceps and inserted into the eye through the 2.8 millimeter incision. Careful exteriorization is done and the lens is put in place. Here comes the artificial iris with fiber. 1 millimeter is subtracted from the white to white measurement of the patient. It is refined using a corneal refine, and the iris is separated. Again, Gore-Tex suture is passed through this, and in the same way, the iris is implanted anterior to the lens. So this was a 3-month post-op result. At 3 months, the post-operative refraction stabilized with 612 parts vision as we had expected, with minus 0.5 sphere and minus 0.5 cylinder at 123 degree. So we can take a patient from a squashed globe to a beautiful visual recovery. So the take-home message is this is a novel and innovative technique for using biocompatible elastomer-based fiber artificial iris. Meticulous primary repair eases the secondary procedure. Aphakia, glare, and extreme astigmatism can be taken care of this novel technique. Long-term follow-up shows excellent visual rehabilitation. Thank you.
Dr. Anand, what about the stability of this artificial iris? You are only hitching at 2 places.
Yes, sir.
Okay. So how does it actually, kind of get that typical iris stability? Because it can be floppy, it can swirl around the thing.
So, sir, actually, the iris is also fixated at 4 points, 2 points each. 4 points. So can we please show the slide if you don't?
Other than the, you're actually, stitching the IOL also.
Yes, sir.
In another 4 points.
Another 4 points, that's
So
right.
4 different points.
4 different points, that's right.
What is intraocular pressure after surgery?
So, madam, intraocular pressure was low after the surgery because of so many sclerotomies. So we had to pad the eye next day. Slowly the pressure picked up. Fortunately, there were no choroidal detachment on B scan. So we kept him on oral steroids, and slowly the pressure picked up over a period of 1 week.
Okay, sir.
No, she meant that since there is no iris,
Okay.
so the post-op intraocular pressure is,
Yes, yes.
it should go up.
Yeah,
should go up.
it was normal, sir, because of the worry that the full size of the company iris would cause rubbing of at the angle. So we had reduced 1 millimeter and refined so that there was a gap between the actual angle and the artificial iris.
Well, if there is no iris aniridia, in these cases, the intraocular pressure tends to go up. Number one. Number two, what I want to ask you is, why did you prefer to have a toric eye in these cases? Because you're never sure how will the SFI will behave, whether it's going to have a tilt, whether you have a proper positioning or not. So why did you go for the toric eye?
So because astigmatism was 4.5, even if we had put a aniridia lens, so that again incision of 8 millimeters plus this 4.5, total we don't know how much he would have been having. So we tried to reduce the astigmatism as much as possible, which was 0.5.
I don't know, but then in SFL having a toric eye is something,
No, it's
and
a,
because
it's
the
not
lens
SF, it's a normal IOL.
It's a normal IOL
Normal IOL, at normal toric IOL, which is stitched to the
which
thing.
stitched to
there
the
is a tilt also of the eye.
Ah, that's an additional thing.
Yeah.
So if you, that is a possibility, but probably it's a gross astigmatism. Probably. What was the outcome? I mean, post-operative
post-operative, sir,
residual
he still
astigmatism.
have he still had
No, residual astigmatism. How much?
was
is it?
0.5.
Okay, that's.
He still had that. The good thing was we could fix it at 4 points. So probably because of that I measured the from the limbus 3 times. Every time is to mark, measure and make sure it is the same so that there is no tilt on either of the sides.
But one thing, this iris would have also probably prevented the tilting of the eyeball.
That's
That would have been
exactly
an
right.
additional anterior stability to
It
the.
had an anterior scaffold which prevented movement.
Yeah, sounds good. And how about thinking about this pinpointed pupilloplastic kind of a very small pupil you could have given so that it takes away all the aberrations?
Sir, in this it is complete and total aniridia, so I did not have the option of.
You had the pupil inside, isn't it?
No
so people
pupil.
could have been
No,
still
can
smaller.
you customize the pupil? We are saying.
Customized.
Can you tell them that I want 2 millimeter pupil?
No,
thin?
sir. So they make exact 3.35 millimeters for all. It's a standard size. So they have come to this.
Normal
company-
scotopic pupil of humans.
Yes, yes.
And do you have a case in point for having aniridia IOLs which also have the toric component? That would be a better solution.
Yeah.
Long term.
so
That's
the-
a case in point for actually going ahead in that direction.
So only problem with that is, sir, the length of the incision is again big.
Yeah, agreed. But then, like sir's point was, the fixation at the sclera itself induces astigmatism. The suture, it will vary from case to case. Right now, you had 0.5 residual, but in maybe a series of 5 or 6 cases, it would vary depending on the.
You can have a foldable toric aniridia IOL, but only the cases are less. That's why there is not much
It's
of a
not.
thing.
It's
Now it's only
and
rigid.
probably customized.
Yeah. In future, maybe we'll have a foldable toric
Toric.
aniridia lenses.
Yes.
Yeah, good try. I
Very
think
nice, very
very encouraging result.
Thank you, sir.